Hi, I'm Allie Ward, Editorial Director of Contagion, and joining me today is Dr. Steven Woloshin, the co-director of the Center for Medicine and Media at the Dartmouth Institute and founder of the Lisa Schwartz Program for Truth in Medicine. Dr. Woloshin and colleagues recently authored a perspective article in the New England Journal of Medicine describing the challenges and implications of false negative tests for SARS-CoV-2 infection. So let's dive right in. Dr. Woloshin, thanks for joining us today. Can you tell us a little bit about what prompted the NEJM perspective article on the accuracy of these COVID-19 diagnostic tests?
Sure. I missed my mother. I wanted to visit her. She's at higher, would be considered at higher risk because of her age, and she lives in New Jersey. And I was thinking of visiting her, and I just wondered whether I should get tested or not. And because of my research, I often am looking at FDA documents, mostly about drug approval. And so naturally, I went to the FDA to just kind of read about the tests that have been authorized under the EUA. And so I started looking at them, and the more that I read, the less convinced I was that, the more concerned I was about the quality of the validation of the studies. And then, after looking at a bunch of them, it ended up, I figured it'd probably be good to communicate what I learned to my colleagues and to others. And also talking to people, there was also, I thought there was some confusion about how to interpret test results in general. And so the article also included a bit on how to calculate test probabilities using the sensitivity and specificity of the test.
Mm-hmm. And do we have any estimates about just how common these false negative tests are?
Well, we do, but I think there's a lot that we don't know, and the evidence is kind of spotty. What we know is if you look at the EUA, the authorizations, the companies are supposed to report sensitivity and specificity. It's a part of the clinical performance of the test. But the problem is often what they're presenting is the percent agreement between the new test and some previously authorized test. And those numbers usually come out to be really impressive. The positive agreements are like in the 95% range. Same thing, the sensitivities are often at 100% level. The problem is that that's not what clinical sensitivity and clinical specificity mean. Because when I want to know how well a test works, I certainly want to know that if I have a specimen with COVID, the virus in it, that the test will identify it will be positive. And I want to know that if I have a specimen that doesn't have this virus in it or the virus particles, whatever it is you're looking for, and I test it, that it'll be negative. That's really critically important. But as a clinician, I want to know if I have a patient who has COVID, right, and I test them, will the test be positive? And that's really different. And the reason it's different is because in the first case, when I have known positive and known negative specimens, I've taken out a lot of the uncertainty that exists in clinical practice, because when I see a patient, I have to take the sample, so I might do that wrong. I might have an inadequate sample. It has to be processed, it has to be transported to the lab. All that sort of stuff might cause problems. Once it gets to the lab, the test itself might not function. And so all these things, there are all these opportunities for error. And the way that the EUA, the percent agreement approach works, you miss out all that it's called pre-analytic phase, all that stuff happens before the actual test is done. And that means that the sensitivity of the test is overestimated, right? Because swabs might not be done right, they might not pick up the virus, or it might be done at the wrong time, when early on or late in the infection, when the person isn't producing a lot of spewing a lot of virus particles, or it may be processed incorrectly, handled incorrectly, whatever. So you need to account for all that stuff. That's what we really need to know how it's actually used in reality. Now, there are none of the tests, none of the EUAs that we looked at provide that kind of information. There are studies, published studies, some are preprints, some are actually published, where there's been an attempt to try to get at this clinical sensitivity. And in our article, we cite meta-analysis that looked at 5 trials, and they gave a range of false negative rates of 2% to about 30%. Then most recently, just about 2 weeks ago, there was an article in the Annals of Internal Medicine, which looked at false negative rates by time, from the time of exposure and along the time course of the infection. And they found, they looked at 7 studies, and they found ranges of false negative rates that were, they did some modeling, but on average, it looked like at the time that someone had symptoms, sensitivity varies according to time. So when at the time that you're initially exposed, there's very little virus in your body, so the false negative rate is really, really high. Over time, over maybe 5 days or so until symptoms start to appear, the false negative rate drops. And then by about 3 days after symptoms appear, or 3 or 4 days after symptoms appear, the false negative rate gets to its lowest point, but it's still around 20%. So it really is, it matters what the timing is of when the sample is drawn. So the bottom line is the evidence is mixed. It's not maybe the best evidence, but it sounds like the best guess is that on average the sensitivity of these PCR tests is probably in the 70% range. I mean, that's the figure that you often see. But this is one of the things that it would really be great if we had better evidence. And so if the tests were subjected to better tests, and that the FDA reported the real clinical sensitivity and specificity in the EUA documents.
Mm-hmm. And you touched on it a little bit in your answer just now, but can you get into a little bit more about what the implications of these false negative tests are?
Sure. The problem is if a test were perfect, then if you tested positive, the person is infected. If you tested negative, they're not infected. That'd be great. But the tests aren't perfect. No test is perfect. And so you have to account for that in how you interpret the results. Because of the false negative rate, when you have a negative test, you may not have ruled out infection. And that matters. If the test has a really low sensitivity, then it's possible that you miss a lot of infections. And that matters because if you tell someone they're negative, they may think that they're clear and they can go out and do what they want. They're not at risk for infecting other people. And that's not the case, because if there are people who have false negative results and they go out and maybe don't practice social distancing or wear a mask or whatever, or go into high-risk environments like a nursing home or prison or something, they may transmit the disease, even if they feel well. I mean, that's documented. So it's a real important issue. That's why it's so important to get a handle on what the false negative rate really is in order to intelligently interpret the meaning of a negative result.
Right, yeah. And I guess complicating matters to some degree is kind of the speed at which manufacturers are creating these tests and the rate that the FDA is issuing these EUAs. How do we sort of balance the need for quickly getting these diagnostic products to market in a pandemic situation, right, with the quality control aspect of making sure that the tests are producing accurate results?
Right, well, that's a great question. And, everyone always criticizes the FDA for being too fast and too slow. And I have a lot of sympathy for them, because I think they're trying to do the best that they can. At the beginning of the pandemic, there was a desperate need to get testing out there. And so, it makes sense that the EUA allowed the companies, sort of expedited the process. But I think now that we have a whole bunch of tests out there, I mean, I think the last time I looked, there was stuff with more than 100 tests. Not all PCR tests, but quite a few. Now I think that maybe it makes sense to start raising the bar and even going back to the authorized testing and asking for more clinically relevant evidence.
Mm-hmm. Yeah. Like you just pointed out, that we need a reference standard for measuring the sensitivity of these SARS-CoV-2 tests in asymptomatic patients. You pointed that out as an urgent issue in your paper. Can you talk a little bit about more why that is such an urgent issue?
So it matters because the idea that testing is kind of a ticket out of this situation, because by testing we're going to identify people who are infected, and then quarantine them and keep them away from people who are at high risk, or from spreading the virus, particularly to people at high risk. But because we know that there is transmission of people who have no symptoms, either they're asymptomatic, so they never develop symptoms through the course of their infection, or who are pre-symptomatic, they're tested before they have symptoms, but they're infectious. It's crucial to know how well the tests work in people without symptoms. And none of the EUAs we looked at evaluated the test in that population. So we just don't know. Now, people without symptoms may be different than people with symptoms. The viral loads may be different. The amount of transmission may be different. Their infectivity may be different. We don't know. And that's crucial information that we need to learn. I mean, there's a lot that we don't know about this virus. And this is a crucial thing that we need to get a handle on in order to make intelligent decisions about how to approach testing.
Dr. Woloshin, thank you so much for joining us today. We really appreciate your time. To read stories like this and more, be sure to visit contagionlive.com.